All right, today we're tackling an organism that many of us in the lab used to brush off as just background noise, but things have changed. We're talking about Corynebacterium amycolatum, and it's absolutely demanding our attention as a major player in clinical microbiology. So this quote right here, it just nails the entire story of Corynebacterium amycolatum. I mean, for years, you'd see this on a plate and your gut reaction was probably, oh, it's just a skin bug, a contaminant. We've all been there. But that's not the story anymore. The script has totally flipped, and we're now dealing with a really serious, multi-drug-resistant threat. So, here's our game plan. We're going to take this from the lab bench straight to the bedside. We'll start with its journey from commensal to pathogen, get into the modern ID workflow, talk about telling infection from contamination, navigate its tricky resistance patterns, look at treatment protocols, and wrap up with infection control. All right, Section 1, from commensal to pathogen. Let's get right into the basics. Who is this bug really, and what's in a name? As it turns out, quite a lot. So let's be super clear about this. We are not talking about some rare, obscure isolate here. This is one of the most common non-diphtherial Corynebacterium species we're pulling from clinical samples. You see it especially in hospitals, right? With patients who have all kinds of indwelling devices. Its numbers are way up. And this is where it gets really interesting. The name itself, amycolatum, literally tells you its secret. A, meaning without, and mycolatum from mycolic acids. This is a huge deal because most Corynebacteria have mycolic acids. It's one of their defining features. So even though gene sequencing puts it squarely in the family, this one key biochemical trait makes it the odd one out. It's a fantastic clue for us in the lab. Okay, let's head over to the lab bench for Section 2. We're looking at the modern identification workflow, basically how we nail the ID on this thing and stop making the mistakes that were so common in the past. When you first work this up, you get some classic clues. You know the look, right? On the gram stain, you see those pleomorphic, gram-positive rods, sometimes in those classic V shapes or Chinese letter arrangements. And on the plate, after a day or two, you get these dry, kind of waxy, grayish-white colonies. The problem is, a few of its cousins look awfully similar, and that's exactly why it was misidentified for so long. And this table, well, this is where the real headache begins. See all those V's for variable? That's the problem. Its ability to ferment sugars like maltose and sucrose is just all over the place. You can't count on it. And if you're trying to tell it apart from its close relative, Corynebacterium xerosis, using something like an API corny strip, good luck. It's just not reliable enough on its own. This is exactly why we've had to up our game. Thank goodness for our modern tools. I mean, MALDI-TOF has been an absolute game changer, giving us fast, accurate IDs right down to the species level. And when things get tricky or we need that final, definitive answer, sequencing is still our gold standard, whether it's the 16S rRNA or the RPOB gene. So now for Section 3, and this is maybe the most important part of our job. You've got the ID. Now what? What do you tell the clinician? Is this a real infection or is it just contamination? Make no mistake, when the conditions are right, this bug is no harmless bystander. It's a major cause of hospital-acquired infections, especially those linked to devices. We're talking about everything from catheter-related bloodstream infections and sepsis to really nasty stuff like endocarditis on heart valves and deep bone infections around prosthetic joints. Its potential to cause serious disease is absolutely clear. So our job goes way beyond just spitting out a name. We have to be detectives and provide context. This is the checklist I run through in my head. First, where did it come from? A sterile site like blood or CSF, that's a huge red flag. Second, do we find it more than once, like in multiple, separate blood cultures? Third, look at the plate. Is it growing like crazy all by itself? And finally, check the gram stain again. Are there white blood cells, a host response? Putting these clues together is how we separate the real threat from the red herring. Now for Section 4. Let's talk about what makes this organism so challenging to treat. Its absolutely brutal resistance profile. This is the feature that really defines how we have to approach it. Okay, here's the bottom line, the big takeaway. Do not even think about using your standard go-to antibiotics empirically. This bug just laughs at most of them. Resistance to beta-lactams, macrolides, clindamycin, fluoroquinolones, that's what you should expect. It's the norm. This is why you absolutely must perform susceptibility testing on any isolate you think is clinically significant. The only things that reliably work are Vancomycin and Linezolid.
And to get that susceptibility data right, we all need to be on the same page, using standardized breakpoints. Here's a look at the current ones from EUCAST for Corynebacterium. And just a little side note on vancomycin, you'll notice there isn't a formal susceptible breakpoint. That's because true resistance is incredibly rare. If you ever see an MIC over 2, that's a huge deal, and definitely something you'd want to send to a reference lab to confirm. All right, on to section 5. Let's connect the dots from the lab to the clinic and look at how these resistance patterns shape the actual treatment protocols.
Internationally, the advice is pretty clear-cut for any serious infection. The first-line agents are vancomycin or linezolid, period. Don't even bother with beta-lactams or fluoroquinolones as your first guess. But here's the part that's just as important, if not more so. You can't just rely on antibiotics. You have to get the source of the infection out. That means pulling the infected line, cleaning out the infected joint. Source control is non-negotiable if you want to cure the patient.
Now, if we look specifically at the Netherlands, there isn't a dedicated SUAB guideline just for Corynebacterium amycolatum, but in practice, the approach is the same. You treat it like any other serious, multidrug-resistant gram-positive infection. That means you're reaching for vancomycin, and importantly, you're using a loading dose and doing therapeutic drug monitoring to make sure the levels are right. Or you're using linezolid, which is a great IV or oral option. And when it comes to kids, you have to throw the adult playbook out the window. Kids are not just little adults. Their metabolism is completely different. They clear these drugs much faster. So you can see here the dosing has to be more frequent. Vancomycin might be every 6 hours and linezolid every 8 hours for the little ones. You absolutely have to consult pediatric-specific guidelines for these patients. Okay, our final section, infection prevention and control. So how do we stop these infections from happening in the first place? It's a tough question, right? Especially when the main source of the bug is living right there on the patient's skin.
Look, we're never going to eliminate this organism from our patients. That's just not realistic. The strategy has to be about building strong defenses everywhere, what we call horizontal measures. It's the fundamentals done perfectly every single time. We're talking obsessive hand hygiene, perfect sterile technique when putting in any kind of line or device, and using proven tools like catheter care bundles consistently. It's about preventing the bug from getting from the skin to somewhere it can cause damage.
Just so you know where all this came from, we put this entire explainer together using a Gemini deep search to get the most comprehensive and up-to-date info on Corynebacterium amycolatum. The incredible images you've seen are all from MicroCanvas. And if you want to dive into the primary literature yourself, we've got a full list of references for you in the accompanying notebook document. So that brings us to this final, really important question. This bug is a perfect example of where the microbiology lab and the infection control team have to work hand in hand. How do we make that connection stronger? How do we turn a lab result into an action that truly protects our patients? I'd love to hear your ideas on this, so please subscribe and drop your thoughts on these IPC strategies down in the comments. Thanks so much for watching.